Dr. Edward, as well as with Edward, they were talking on common things what are possible in the perioperative scenario when a kidney is being operated. And you have noticed, both were pointing on to one particular direction. That is a volume status and the infections. Whether it is hyperolemia or the hypovolemia, which is going to produce hypertension or hypotension. And this is a one killing factor, especially in a transplanted patient, in the perioperative phase. Here, we are going to hear from Dr. Suresh Nair, who is the next speaker. What is the fluid responsiveness and how correctly fluid could be administered in the perioperative settings in a transplant surgery. Suresh Nair, well, you know, is a lead consultant with the Aster Group of Hospitals, now at Kochi, Kerala. And he was early with the Amrita Institute of Medical Sciences, Kochi, and further to that with the Shitra Institute of Medical Sciences, and earlier he had his graduation and post-graduation from Vadodara Medical Institute. And Suresh is an AS anesthesiologist and is an excellent academician. And he was with us for the last 3-4 conferences of the IATA, Critical Care Medicine, as well as a zonal meeting, as well as a SACA meeting, as a scientific committee organizer, scientific conductor of the conference. Here is Suresh with you to discuss on responsiveness to fluid in a kidney injured patient. Over to you, Suresh.
Thank you, sir, for the kind introduction. And first of all, I would like to thank the organizers for giving me this opportunity to be here. The topic that has been given to me is about dynamic indices of fluid responsiveness. Now, we all know that fluid therapy remains a mainstay in the management of patients with circulatory shock. The basic aim when you give fluids is that you improve the stroke volume and the cardiac output of the patient and thereby improve tissue perfusion as well as oxygen delivery to tissues. Basically, what it means is that you allow the patient to move up the vertical portion of the Frank-Starling curve. Unfortunately, 50% of the patients whom you think needs fluids are non-responsive to fluids. Now, over the years, we have multiple papers that has actually come up which shows that both inadequate as well as over-enthusiastic fluid administration is usually associated with poor outcome. And this is particularly so in patients with ARDS or in septic shock. And therefore, in the past, we used to depend on what you call clinical indices and certain static indicators to assess whether the patient is actually fluid responsive. Unfortunately, these are not accepted anymore. Now, what is in practice is what is called the dynamic indices of fluid responsiveness, or you can also say preload reserve, whether they can improve their cardiac output with fluid load. Now, to do that, you need two things. One is you need an efficient monitor which will rapidly assess what is the stroke volume or change in the cardiac performance. And then you evaluate whether the patient has got a preload reserve. This can be done in two ways. One is you give a fluid challenge to the patient, which we'll discuss later. Or if the patient is on mechanical ventilation, you assess the heart-lung interactions. And based on this, you can find out whether the patient has got a preload reserve, which means that if you give fluids to these patients, they will improve their stroke volume and cardiac output. Now, this is the roadmap for the next few minutes. Now, what is fluid responsiveness? Let me define fluid responsiveness. Fluid responsiveness means there is an improvement in the cardiac performance of the patient in the form of either stroke volume or cardiac output when you give 250 to 500 ml of fluid in a short period of 15 to 30 minutes. Now, remember one thing important. The mere presence of fluid responsiveness is not an indication for giving fluids. It should always be accompanied by signs of tissue hypoperfusion. This is very, very important for all the postgraduates to understand. What it does is that when you give fluids, it converts what is known as the unstressed venous volume into a stressed venous volume. As a result, it produces a gradient between the venous system and the right atrium. More fluid goes to the right atrium, which ultimately transmits itself to the left side of the heart, resulting in an increase in the left ventricular end diastolic volume. And as you all know, the larger the left ventricular end diastolic volume, the most forceful the myocardial contractility up to a certain point. Now, what are the monitors that can be used? I'm going to go through this very rapidly because morning Dr. Kishore has already discussed this. The first part of the slide I'm going to omit because they are the static indicators, the CEP, the pulmonary artery occlusion pressure, the left ventricular end diastolic area attained from the echocardiography or the global end diastolic volume. Now, to say that these are obsolete measures of cardiac volume status, it would be too strong a statement. I would not do that. They still have a place, but they are not used, no more very active in clinical practice. The most popular among all these cardiac output monitors is the transpulmonary thermodilution catheters, which means that it has got two parts. One is it generates the cardiac output using a cold saline, or as in the case of LIDCO system, they use lithium to dilute, produce a cardiac output curve. In the process, they take out what is known as a coefficient factor. This coefficient factor is then used to assess the stroke volume beat by beat from the pulse contour analysis. This is two parts. There is a cardiac output and a pulse contour analysis. On the other hand, we have monitors like the flow track, most of you must be familiar, which does not use a cardiac output generator. What it does is that it looks merely at the pulse contour analysis, and based on an algorithm which is based on the age, weight and sex of the patient and the aortic compliance, they generate the stroke by stroke, beat by beat assessment of the stroke volume and the cardiac output. Remember this is called the uncalibrated cardiac output monitor. The previous one which I mentioned was the calibrated cardiac output monitor. These are the best monitors because they can assess a change in stroke volume even as low as 1 to 2%. They're the best monitors, but they're expensive. The other thing that we can easily use in most of our ICUs is the esophageal, the ultrasound-based technique. What it does is that we look at what is known as the, what is known as the velocity time integral. Now, this velocity time integral is nothing but the amount of blood that passes through a single point during each beat of the heart. Now, we assume that the aorta is circular in shape, it's not going to change its shape very frequently. And if you know the cross-sectional area and the amount of blood that passes through a single point, you can easily make out the cardiac output. Now, various devices are there. You have the esophageal Doppler, which measures the descending aortic blood flow. Then you have the transthoracic echo or the transesophageal. All of us, many of us at least, will be familiar with this technique. Again, it gives you a very good assessment of the beat-by-beat changes of the stroke volume and cardiac output, but the sensitivity is much less than that of the calibrated and uncalibrated cardiac output monitor. A new kid on the block is a plethysmographic variability index. This has not been validated to a great extent. There are a lot of work to be done in this area, but it's still one of the monitors that is being used. The other simple bedside monitor is based on the concept of a change in the carbon EtCO2. If the EtCO2 changes by more than 2 millimeters of mercury, it means there's a change in the increase in the cardiac output. This is based on the scientific principle that the carbon dioxide that is in your blood is from three sources. One is the tissue metabolism, the other is the minute ventilation that you set up, and the third thing is the cardiac output, which is equivalent to the pulmonary blood flow. Now, if you don't change your minute ventilation and the tissue metabolism, which is not likely to happen over a few seconds, then the only factor which can cause an increase in the EtCO2 is your cardiac output. So, if your cardiac output increased by 10 to 15%, it means that the EtCO2 will change by 2 millimeters of mercury. So, this is something which all of us can use in our ICUs or OTs. The last thing is the transpulmonary and the thoracic bioreactants. This is based on the principle, again, that the ejectile, the pulsatile nature of the aortic blood flow produces changes in the electrical conductivity of the across the chest wall. This is utilized by using various electrodes, and the frequency change and phase shift actually tells you what is the stroke volume that is generated. So these are the monitors that we can make use of at the bedside or in the operating room to identify the changes in the cardiac output. Now let us look at the basis of what I have already said. First part is already over. We have already seen that the monitor is needed to be there. The second part is the assessment of the fluid responsiveness or a preload status of the patient. How do you do that? As I said earlier, increase the preload to the patient either through an external fluid challenge or through an internal fluid challenge. The second option is The patient on mechanical ventilation, study the heart-lung interactions, and on the right side you will see the monitors that we have already discussed, which we can use routinely. Now, what are the dynamic indices based on fluid challenge? The easiest thing that we can do is administration of 250 ml of 500 ml of fluid over 15 to 30 minutes. And if your cardiac output increased by 10 to 15%, it means that the patient has got a preload reserve. It can be assessed by either of the any of the cardiac output monitors, your calibrated or uncalibrated cardiac output, your velocity time integral, or the stroke volume variability and pulse pressure variability are less sensitive, but they will show a downward trend. The major problem with giving external fluid challenge is that you may have to do it multiple times in a day. And in the process, you may end up by giving too much fluids to the patient. So that is a major problem with the external fluid challenge. So now we have what is known as the internal fluid challenge. And the easiest test that we can do in the ICUs particularly is the passive leg raising test. What it does is that if a patient is in the recommend position, you bring him this trunk back to the normal horizontal position, raise his legs by 30 to 45 degrees. What it does is that it transfers about 300 to 500 ml of fluid from the splenic and the lower limbs into the central circulation, and this will produce an increase in stroke volume and the cardiac output of the patient. But remember one thing, the maximum change in stroke volume and cardiac output produced by PLR test is at 1 minute. So the test has to identify, whatever monitor you use has to identify this change in 1 minute. Now, the advantage is that it can be used in patients who have no cardiac arrhythmias, who are on spontaneous ventilation, and it has validated it has got very high sensitivity and specificity as well as positive and negative predictive values. Now, it is ideally monitored by one of the cardiac output monitors which I mentioned earlier. Now, esophageal Doppler or transthoracic or TE can be used. People have started looking at the femoral artery VTI as well as the carotid. Dopplers can be used to assess the change in the stroke volume. A change in the end-tidal carbon dioxide by 2 millimeters again tells you that the patient has got a preload reserve. And PPV is not a sensitive indicator. You should not look at the PPV for various reasons. Now, what are the limitations? Cannot be done in patients with raised ICP or in the operating room. If starting with the patient already in the supine position, then if you just raise the legs, the amount of fluid that can be given transferred will be less and you can get a false negative test. It should not be used, or it may be not have a significant effect in patients who are on venous compression stockings, those who are on vasopressors, especially Norelden because of its venoconstrictive effect, and raised intra-abdominal pressure. The other test which produces internal transfer of fluid is the end expiratory occlusion test. What it does is that now, just to go back to the physics of this, is that when you ventilate a patient, as your intrathoracic pressures rise, two things happen. One is your preload decreases, the venous return to the right heart decreases. At the same time, there's an increase in the right ventricular afterload, which produces a reduction in the right ventricular stroke volume, which over a period of time will be transmitted to the left side of the heart and you get a reduced stroke volume. Now, if you interrupt the ventilation for a few seconds, what will happen? There is an increased preload to the patient. And this is made use of in the end expiratory occlusion test. Now, what you do is the important thing to remember here is that it takes about 12 seconds for the changes that happens on the right side of the heart to be transmitted to the left side of the heart. So, your end expiratory occlusion test should be at least 15 seconds. The other important thing to remember is that end expiratory occlusion test, the cutoff value is 5% cardiac change in stroke volume or cardiac output. That means if it increases by more than 5%, it means that the patient has got a preload reserve. Now, the problem is most of the monitors are not sensitive to identify this small change in stroke volume. Your calibrated and uncalibrated cardiac output monitor can be used very well, but do not use what you call the echocardiography measure because it is too insensitive. So what they have done, they have found out they can what they have found out is that you combine end expiratory occlusion test with the end inspiratory occlusion test. So as you can see in the figure below, so this is a normal stroke volume that is VTI that is generated. Then you hit the button for end expiratory occlusion. As you can see, the stroke volume increases or the VTI increases. Put the patient back on normal ventilation for a few seconds and then hit the button for end inspiratory occlusion. And if the changes that is seen in the VTI combining the end expiratory occlusion plus the end inspiratory occlusion is more than 13%, it means that the patient has got a preload reserve. That is called the end expiratory plus end inspiratory occlusion test. Now let us come to a dynamic index based on heart-lung interactions. Now again, coming back to the physiology during normal ventilation, as I said, when the intrathoracic pressure rises, your right ventricular afterload increases, your preload to the right side of the heart decreases. Another thing that happens is that in the first few seconds, as the intrathoracic pressure rises, it squeezes out the blood from the pulmonary circulation into the systemic circulation. As a result of which, in the first few seconds during the inspiratory phase, or towards the end of the inspiratory phase, you will find that the maximum stroke volume towards the end of the inspiratory phase and the minimum stroke volume during the end expiratory phase. So this is normal physiology that occurs during the curve. Now what can be used simple by bedside? Your stroke volume variability as well as the pulse pressure variability. These are measures. How do you measure this? Remember one thing, pulse pressure variability is a directly measured variable. The stroke volume variability is a indirectly measured variable. Now, there are multiple limitations. All of us, today, any monitor that you buy today will have PPV established into that. Stroke volume variability is something you get from one of the cardiac output monitors. Now, there are a number of limitations. It can be identified by the acronym LIMITS, which basically means high respiratory rate, irregular heart rate, mechanical ventilation with low tidal volume. Today, most of us use low tidal volume. It cannot be used for that. Increased intra-abdominal pressure, a chest which is open, especially cardiac surgery is no longer used. Spontaneous breathing gives you false negative values. Now, we still do not know what happens to PPV and SVV in patients with impaired right ventricular function. And remember that a value of SVV more than 12% or a value of PPV more than 13% is considered as a fluid responsive patient. A value less than 9% is considered as fluid unresponsive. And remember, we have a gray area between 9 to 13% where you still do not know whether the patient will respond or not. Now, how do you overcome? If you have a patient who has got a low tidal volume ventilation, you want to find out how to, whether patient, and you are in the gray area or you don't know, PPV is normal. That Sheila Maitra, who from Bombay, has done a study called the Tidal Volume Challenge, in which patients who are on 6 ml per kg tidal volume, the tidal volume is increased to 8 ml per kg for a short period of time. And if your PPV increases by more than 3.5% or your SVV increases by more than 2.5%, it means that the patient is in fluid, that's got a fluid responsive state. To take that step one step further, other people have, what they did is that if your SVV and PPV value falls in the gray area, you are ventilating with 8 ml per kg, you increase it to 12 ml per kg for a short period of time, and if this value goes up, it can be considered that the patient is fluid responsive. The simple bedside test is a systolic pressure variation. In this, going back to the mechanical ventilation, that is the fluctuations in the stroke volume with each beat of the heart. You have to take a baseline systolic variation, which is towards the end of expiration. And they say that if your the minimum, that's called the delta down, is more than 5 millimeters of mercury, it means that your patient is hypovolemic. Then there is something more we have to understand about PPV and SVV. Now, when we give fluids to a patient, we always believe that it will increase the stroke volume and the cardiac output. But if you want adequate tissue perfusion, you need one more thing, that is adequate tissue perfusion pressure. Now, this is influenced by various factors, including the arterial resistance, impedance, pressure reflection waveform. All those factors have to be considered when you say that your fluid has actually improved tissue perfusion. Now, the ratio of PPV to SVV, if you take, it can tell you what is the state of FS in the tissues. Now, if your value, that PPV by SVV value is more than 0.9, it means that if you give fluids to a patient who is fluid responsive, it will increase not only the stroke volume and the cardiac output, but it also will increase your tissue perfusion pressure. That means pressure will also go up. On the other hand, if this value is less than 0.9, it means that along with the fluids, you also have to add a vasopressor agent to produce an adequate tissue perfusion. The last thing is the inferior vena cava collapsibility index. Now, I'm not very excited about this because numerous studies, there's so many limitations with that. It It is obtained from the subsiphoid view. You keep your probe in the long axis view. The cutoff, you have to use the M mode or direct measurements about 1 to 3 centimeters from the point where it joins the right atrium and after the hepatic vein joins the IVC. The problems with that is that unreliability because of numerous limitations, especially in patients who are breathing spontaneously. If your lung is bad and low tidal volume ventilation, and of course if there's raised intra-abdominal pressure, IVC collapsibility cannot be considered as a indice of fluid responsibility. So let us come to clinical utility, a few seconds on that. Can dynamic tests be used in patients in the prone position? Now this is very difficult to answer because many of the tests that we have discussed cannot be used, but PLR may be used by producing the Trendelenburg position that will allow more blood to go into central circulation. End expiratory and end inspiratory occlusion tests can be used, and the tidal volume can be used in these patients to assess the fluid responsiveness of the patient. The mini fluid challenge. Now, as I said earlier, when we give a normal fluid challenge, it may end up in the patient receiving more fluids than is actually required. Now, the mini fluid challenge means you give only 50 to 150 ml of fluid in a very short time of 1 to 2 minutes and then assess the change in the cardiac output. The cutoff value is more than 5%, and one of the cardiac output monitors can be used to assess the change in the cardiac output. The next question is, when to do a dynamic fluid responsiveness test? Now, this is specifically for the postgraduates. Do not waste your time when a patient is obviously in circulatory shock. Because it may be in the resuscitation phase of septic shock, or it may be a patient who is obviously bled and brought into the ED or into a theater. Do not waste time, give fluids to the patient. There will come a time when you don't know, when you have given adequate fluids, the pressures have started going up, when you are not sure whether more fluid is required in this patient or not. And remember that at this phase, at this point of your resuscitation, only 50% of the patients will respond to fluids. So that is a phase when you have to do a dynamic or fluid responsiveness test. Next question is, does FR mean that fluid should be administered? I've already told you, the fluid responsiveness doesn't mean that you have to give fluids. It should always be accompanied by signs of tissue hypoperfusion. You and me sitting here are all fluid responsive. It doesn't mean that fluid should be pushed into us. So what are the indices of tissue hypoperfusion? Your capillary refill time, your mottling score, your arteriovenous carbon dioxide difference, all these can be taken in a critically ill patient and then assess whether the patient really needs fluid. Now, if your patient is fluid responsive and also has signs of tissue hypoperfusion, just 2 minutes more, sir. Fluid responsiveness. Then you have to weigh the benefits of giving fluids versus the risk of giving fluids. For example, if I have a patient who is in ARDS and I know his lungs are already wet, I would hesitate to give more fluids to this patient. On the other hand, if I have a patient in septic shock, I have resuscitated him partly, and he shows signs of tissue hypoperfusion still, then I would not hesitate to give more fluids to the patient. So even after the patient is showing signs of tissue hypoperfusion, you still have to weigh the benefits and the risk. The last couple of slides, I want to tell you what are the outcome benefits. Is there any literature based on this dynamic indices? Now, I have no time, but I'll tell you briefly. This can be divided into two groups. One is the surgical cases. Most of the surgical cases which have looked at dynamic indices have shown that using fluid responsiveness as an indicator to give fluids is associated with reduction in the duration of mechanical ventilation, ICU stay, hospital stay, reduction in the mortality or trend towards that. And when you combine this with what you call the goal-directed therapy, it has shown the definite trend towards reduction in the mortality and a significant reduction in the post-operative pulmonary complications. So this is one area where as anesthetists we can develop a lot more. When you come to the medical side, there is some evidence, but not very strong, but they still say that using fluid responses in septic shock patients has not done any harm, so you can still go on with it. So in summary, over-infusion as well as under-infusion is bad for the patient. Static indicators are not accepted, especially in a forum like this. Dynamic indices are simple techniques. We can use sophisticated monitors, but like I said, the ET suite is such a simple thing you can use at the bedside for every patient. You can look at the PPV. All these are definite bedside monitors that can be used to assess the fluid responsiveness of the patient. And remember that dynamic indices in combination with goal-directed therapy is an unexplored area which we can explore again. Thank you very much, and greetings from Aster Med City.